eso. Bueno, buenas tardes a todos por participar en esta sesión educacional que ya es la número 22. Y hoy tenemos el placer de tener a dos invitados amigos, el doctor Ricardo K Kalil, que es jefe de los Laboratorios de Patología, Cirurgica y Microscopia Electrónica de Brasilia, Brasil, y profesor consultante del Camargo, ¿no? Del Instituto de Oncología Camargo. I would like to thank the attendees from Taiwan. I can see here many people from Taiwan, Professor Wang, so I can identify some name, but anyway, thank you very much to be here. Thank you also to Professor Jombar and to Dr. Gambarotti, because I know that the case could be related to Dr. Gambarotti, and I asked him to be here today for this presentation. So let's start with the Dr. Ricardo Kalil presentation, and then we will going to continue with Dr. Hugo Domínguez, that hopefully he will be show up in the next minutes, I hope. Okay, Ricardo.
Compartir pantalla.
Yeah.
Bueno. Déjame ver. Bueno.
Perfecto.
Hecho. Todos están mirando, ¿me oyen bien?
Sí. Yes. Bueno, sí, perfecto.
Bueno, esta es una presentación de un caso muy interesante que fue visto en la ciudad de Porto Alegre, como Isidro me presentó como trabajando en Brasilia, pero me retiré de Brasilia hace poco tiempo y ahora estoy en la ciudad de Porto Alegre, en el sur de Brasil, en el Hospital Moinhos de Vento, que es asociado al Johns Hopkins, ¿sí? Solo para presentación. Es un caso de un niño de 5 años de edad, mejor en inglés, ¿no? It's a male 5 years old with a tumor in the right eye, noted 5 weeks before. There was no other symptoms, no pain, limping, no weight loss or other symptoms. But lastly, the lesion was slowly growing and beginning to cause some pain. And this is the X-ray of the patient. You can see a large, huge lesion in the thigh of this infant, this guy. Looks like mostly constituted by soft tissue, but also some mineralized or bony, maybe, areas that can be seen already in the X-ray. The MRI showed this large lesion just opposite to the femur, but you can see that the cortex is very well preserved, either here or in the other incidents. This is a coronal view, and this is a sagittal view. And you can see a very well delimited large lesion just opposite to the posterior medial aspect of the femur. So, and in axial view, you can see that this is with contrast. There is some vascularization that can be seen here. Okay, so this was described as an expanding lesion just opposite to the femoral diaphysis, about 15 centimeters wide, large one, with evident signs of mineral. And the radiological first diagnosis was a malignant lesion, maybe osteosarcoma or synovial sarcoma. And with that diagnosis, it was submitted to a needle biopsy, and the needle biopsy retrieved these small bits of cartilage among hemorrhagic material. You can see here, a very well differentiated cartilage with small nuclei of the cell, not very cellular, the lesion also. is hyaline cartilage. And sometimes small areas of connective tissue are seen just opposite to the cartilage. So the biopsy report ran as a low-grade chondrogenic possible neoplasia, that which was very unusual for the age and for the site in this patient. And so it was presumed that it could be a component in another tumor like an osteosarcoma or other one. At surgery, the surgeon told that the lesion was well delimited, almost encapsulated, and mobile without any connection to the bone cortex. So the lesion was in soft tissue. And here you can see the cut surface of this lesion, very well delimited, with composed of nodules of a yellowish soft material with many chondroid nodules dispersed inside this yellowish tissue. This area, is the hemorrhagic area, was probably the one that was hard, like the consistency of bone. And in the microscopy, we could see a well-delimited lesion. You can see the striated muscle surrounding the lesion, a kind of compressed tissue, a pseudocapsule, and inside it, a nodule of cartilage. This nodule of cartilage was very frequent inside this connective tissue. You can see some more immature areas here beginning to form, like in a metaplasia, that like this connective tissue was suffering a kind of metaplasia to cartilage. And here it's much more evident, this transition from connective to cartilage. The cartilage itself was very well differentiated, like in the biopsy. Small nuclei, not very cellular, so looked like a benign lesion. The connective tissue was made of strands of spindle cells, very much uniform, with small nuclei that gradually made a transition to cartilage, like here, and the cartilage, for its turn, made a transition to bone, like you can see here, just like a ossification nuclei of a long bone or a growth plate of a long bone. Here and here, you can see that. In a close view, this is very similar to a growth plate here, and this cartilage is producing bone by an endochondral mechanism, like you can see here, very typical. Okay. In a closer view, you can see that even the cells are very similar to a growth plate, because they even show a maturation and a colonization in the direction of the bone that is being formed here. And the bone itself is lined by osteoblasts, as you can see here. Okay, another view of the same aspect: colonization of the cells, hypertrophy, maturation. And the bone itself was very mature and showing sometimes fat or hematopoietic marrow, like you can see here. In another places, the bone was originated directly from the connective tissue. Here, and here you can see more clearly the osteoblasts rimming the bone trabecula. Well, let's focus somewhat in this connective tissue to show the parallel strands of these spindle cells with dispersed and vascular network. And sometimes it was a little bit with a tendency to be a mixoid. And in these areas, the collagen fibers stand up like this, or here in this other photograph. In other areas, the tissue was more compact, and the cells were, the nuclei of these spindle cells were more elongated and showed some slight, if you can say, atypia or hyperchromasia, and even some mitosis. Okay, higher view here. You see the same spindle cells proliferating. And here a slide showing a more compact area. So, in conclusion, this was a benign lesion. We think it was a benign lesion composed of fibrous tissue, cartilage, mature cartilage, and mature bone, metaplastic cartilage. So, Isidro, would you like to present those questions to the people to see what they would vote for?
Yes.
First, as a first impression.
Yeah, this is, yes, this.
Yes.
The people can vote.
The first question would be, considering the morphology of this case, which would be your more probable diagnosis? And we ask people to vote in the chat. Okay, this is the first question. Okay. The second one.
This is the results.
This is the
result. The result.
Okay.
Okay.
Myositis ossificans, fibrous dysplasia, fibrocartilaginous mesenchyma, no desmoplastic fibroma, hamartoma chondromesenchymal 1. Okay, very good.
I will show the other question. Sorry. Wait. Okay. This is the second question.
The second question is, which of the following results would facilitate in a simple way the final diagnosis in this lesion? H&E, cartilage similar to a gross plate, immunohistochemistry, mutation of GNAS, mutation in IDH1 and 2, or amplification of MDM2. So the answers were?
Let's see. 5 seconds. Yes. Okay. Those are the results.
Okay. H&E was the preferred by most people. Yeah. Okay. Very good. Very good. Yeah. Thank you. So we decided to investigate a little more this lesion. Let me see. Here. The possible diagnosis that we entertained here were chondrosarcoma was at first thought that the biopsy was discarded, and we thought that it could be a kind of heterotopic ossification. And this is just a list of the possible diagnoses: myositis ossificans, fibrodysplasia ossificans progressiva, some kind of neoplasia, like leiomyosarcoma, liposarcoma, because of the yellowish color, a desmoid tumor, a low-grade osteosarcoma, fibrocartilaginous hamartoma of the chest wall, fibrocartilaginous mesenchyma, or fibrous dysplasia, if it was in bone, of course. So for heterotopic ossification, I would recommend to read this very nice paper from Caroline Myers and the people from the Johns Hopkins Pathology. They are very good review on heterotopic ossification. And myositis ossificans, we thought we almost discarded because histologically it's more mature at the periphery and more immature in the center. Like there is the zoning phenomenon that is very clear, and it is not what we can see in this. And also cartilage is very rare here, although it can happen. Fibrodysplasia ossificans progressiva is a kind of ossification that runs parallel to the native skeleton, but it develops inside the native soft tissue and not encapsulated like it is in this area. And it also, it can show almost all of these tissues that we could see. Chest wall hamartoma is we can see the similar cartilaginous nodule, but they occur. All cases described were in the chest wall of infants, and they usually contain aneurysmal bone cyst-like component. Desmoid tumor, there is a paper from Birra and Associates in which he described the desmoid tumor of bonus and chondromatous nodules that was mistaken for chondrosarcoma. But he describes that the cartilaginous nodules in the desmoid tumor are considered secondary and originating from the pelvic apophyseal cartilage. So it was native cartilage that was included in the tumor. Since we are dealing with a soft tissue tumor where we couldn't find, there is no cartilage, so we can maybe discard this other diagnosis. It's interesting that Mira suspected that at least some of the fibrocartilaginous mesenchyma described by Dalin actually represented desmoid tumors and were radiographically, histologically, clinically most consistent with this tumor. So that was his opinion that he mentioned in this paper and also in his book. Well, we made additional studies just to discard some. SATB2 to discard an osteogenic neoplasia or some lesion related to fibrous dysplasia that we know are positive for SATB2. Smooth muscle actin to discard the possible leiomyosarcoma, well differentiated. Beta-catenin for desmoid. S100 for maybe a neural tumor. MDM2 for possible well-differentiated lipo. And all of these were negative, everything negative. And the proliferation index of KIMS30 was less than 1%, very hard to find. We made also FISH to exclude a possible different presentation of myositis ossificans, but it was negative for USP6. And this is just to illustrate the smooth muscle actin with internal control, it's negative. And SATB2 also negative, just positive in the osteoblasts rim the trabecula. You can see here. Okay, as for diagnostic molecular pathology, we find only one paper that was from Marco Gambarotti and the Rizzoli, that where he did a research on GNAS, IDH1, IDH2, and amplification of MDM2 in fibrocartilaginous mesenchyma. It was negative. So we remain with this final possible diagnosis that we think is the correct one. It's at least is my thinking at this moment. This lesion was described by Dali in 1984 as a fibrocartilaginous mesenchyma with features of low-grade malignancy. And he described it as a lesion with benign cartilaginous, histologic appearance is one of benign cartilaginous islands with some hamartomatous features, which the histology really looks like, in a background of proliferating collagen-producing spindle cells, very similar to what we are seeing. Puni and Bertoni, in some years later, 9 years later, described in a review of the Mayo Clinic cases, they said that they certainly believed that the lesion was a neoplasm rather than a hamartoma, because some of their cases recurred after resection. But the lack of evidence of distant metastasis in any of the patient studies suggests that this lesion should not be considered malignant. So they suggest to drop the low-grade malignancy adjective. And the WHO, the last edition of the WHO, which was wrote by Marco Gambarotti, which is here with us, describes fibrocartilaginous mesenchyma as a locally aggressive neoplasm composed of spindle cells with mild cytologic atypia, nodules of hyaline cartilage containing areas resembling growth plate-like cartilage, and bone trabeculae. To me, it's what we are seeing in this case. He said until that moment, there was less than 40 reported cases, all in bone, no one in soft tissue, and it affected young patients between 3 months old and 27 years. So this was the answer to the question. In my view, I agree with most of the people that it is a fibrocartilaginous mesenchyma in this case. And also I agree with the answer that H&E is the best and more simple method to make this diagnosis. So in summary, we presented this kind of fibrocartilaginous mesenchyma, only that the only thing that we have to consider is that it is in soft tissue. And I was not able to find any description of this lesion in soft tissue. This would be maybe the first case. And this is the people who helped me with this case to produce the pictures, the molecular study, immunohistochemistry. Okay, thank you. And this is bibliography. Okay, can I interrupt it?
Yes, thank you very much, Ricardo, for this nice presentation. So the attendees may ask, and I would like to know the opinion of the attendees, especially from Marco Gambarotti, Professor Gambar. So Marco, please.
I'd like very much to hear the opinion of these people.
I totally agree with the diagnosis, particularly when you have some atypical features. I remember that when we wrote the chapter on the WHO book together with Professor Inwards, I have general cases with low, similar to a desmoid morphologically, while we had cases with more, that is, I think both are present in the book, with more atypical feature on the spindle cell. So what here is also the atypical feature of spindle cell. That was the reason why it was called originally low-grade malignancy. Why you can have also a pattern typical, identical to desmoid fibromatosis. The funny thing is that I think we don't know the exact clinical feature. Is the first case of tissue, but there was another thing that this is described as a locally aggressive tumor, never metastasized in the WHO book. But when I was at the last International Skeletal Society meeting, I don't know who, but maybe Fambus Smith, I don't remember, presented a case that finally became a sarcoma. So we know that also fibrodysplasia, every benign lesion, giant cell tumor can become malignant, of course, so it can be an incidental finding, but we cannot exclude the possibility that this can also a pre-malignant lesion. So I think that either we have to rewrite something in the chapter on the WHO book according to better describe these entities. There is something that we don't better know. It's not really known.
Okay. Thank you.
Any further question or remark? Professor John Barr,
Nothing to add,
Professor.
just to congratulate for this very interesting case, which is very unusual. Congratulations, Ricardo.
Thank you. Yeah, it was a unique case. I was not able to talking to people who have experience in this in various parts of the world. They have never seen that.
Very nice case.
Yeah, very nice. Yeah. Oh, I think that maybe I don't know if ossifying fibromyxoid solid tumor could be in the differential diagnosis if we see in soft tissue, of course, because we know that this tumor maybe sometime may reveal chondral or ossea metaplasia, and with this fibrous component, so this could be also included in the differential diagnosis. It's only a speculation. So
Yeah.
because this is a new entity that we don't know so much of this. We know that you have a specific translocation, but anyway.
Yes, we have to do some molecular studies to see. Maybe in the future we could make this diagnosis with molecular, which we are not. We don't have it very easily available here.
But you have really convincing that in this case the H&E is basically for the final diagnosis.
For the moment, yes.
Standard, no?
Yes, the gold standard may be for this diagnosis, I guess. So, Dr. Domínguez, any question, remark, or we continue with your case?
Sure. Should I share the
Yeah.
Yeah.
So, Professor Hugo Domínguez Malagón is a doctor from the Instituto Nacional de Cancerología, Ciudad de México, México. Es un experto también muy bien conocido en partes blandas y huesos y la verdad que contentos también con que nos presentes un caso, Hugo. Y nada, cuando quieras compartir pantalla y comenzar.
Esta compartir pantalla.
Sí.
Bien. Ya puse compartir pantalla. La siguiente. ¿Qué hago?
Sí.
Tengo la presentación minimizada. ¿Qué hago?
Sí. Todavía no aparece como que ha compartido pantalla. No.
A ver.
Si puede abrir primero ¿ya tiene PowerPoint abierto?
Lo abro primero.
Sí.
Ahí está listo.
Vale, ahora abajo donde dice compartir pantalla, si le da a la flechita.
A ver. Es que nada más veo un pequeño cuadro en la pantalla.
Quizás porque esté en pantalla completa. Si puede poner en no pantalla,
Okay.
¿vale?
Ya se me borró. Tengo problemas ya hace rato con esto.
¿Usted ve la flecha de compartir pantalla abajo?
No, no se ve.
No. Y a la derecha, ¿no ve algo que dice vista? Arriba, en el Zoom. Arriba a la derecha en su Zoom debe ver algo que dice vista.
No.
Perdone, Hugo. ¿Nos está viendo a nosotros? ¿Está viendo a Isidro en la pantalla?
No, nomás estoy viendo una pequeña cuadrito.
¿O está viendo el PowerPoint en la
Este,
pantalla?
No, no estoy viendo el PowerPoint.
¿Está viéndonos a nosotros en la pantalla? ¿Está viendo Isidro?
A ver. Ahí sí. Ya estoy
Vale.
viendo a todos.
Vale.
¿Le doy
Entonces abajo.
compartir pantalla?
Efectivamente, sí.
Ya está. Ahí aparece, a ver.
Perfecto. Ahora el PowerPoint, muy bien.
El PowerPoint. Ya está.
Ok.
Entonces,
Sí,
pero
sí.
parece
La
portada de la
copita,
pantalla.
exactamente, la copita esta para poner en pantalla completa.
Ya.
Perfecto. Muy bien.
Ok.
Mm.
Empiezo.
Sí, gracias.
Good morning. Good morning and good afternoon, everybody. I'm Hugo Domínguez from Mexico. My case is going to be very similar to what you have seen. Probably you will question about why did we present a similar case. The difference is that this is a more typical case, a bone tumor that has the H&E that is important for the diagnosis. This was a 7-year-old female with a two-year history of left shoulder pain and microfractures in the bone. X-rays and CAT showed an expansive osteolytic lesions involving the proximal metaphysis of the right tumor. With popcorn densities, which means a chondroid matrix. This is the TAC and the reconstruction of the TAC. And here is another one with the popcorn matrix involving the bone, expanding the cortex, and showing that the lesion is more or less circumscribed to the bone. Here, you will see what was lacking in the previous case. Here is the typical columnar arrangement of the chondrocytes, which mean a gold plate with encondural ossification. And this matrix, and this stroma, which is rich in vessels, in blood vessels, and containing a lot of erythrocytes. In this slide, you can see the osteoblasts surrounding the encondural ossification. always arranged in this columnar fashion. A diagnosis was fibrocartilage mesenchyma. I'm not going to stop in the differential diagnosis, which was excellently presented by Dr. Kalil. It's a rare entity. To date is about 35 or perhaps 38 cases published. Was described by Darling in 1984. It's a disease of young people. It's a poorly delimited lytic popcorn matrix, sometimes with vertical distortion and expansion to the soft tissue. The diagnosis is made at three components. We have spindle cells that is always in different proportions. Spindle cells, cartilage, and islands. In this case, there were almost no spindle cells. It was a matrix that resembled perhaps nodular fasciitis, but there was no spindle cell. It is islands of cartilage and bone production in the form of an chondral ossification. The morphological hallmark are islands of cartilage with chondrocytes arranged in parallel columns like growth plate, which is clearly shown here. And the chondral ossification. Here's an example from the literature in which there are spindle cells. So that makes that the differential diagnosis is with fibrocartilaginous dysplasia, differentiated sarcoma, well-differentiated osteosarcoma, and desmoplastic fibroma. The chest wall mesenchyma can be very similar, but it's exclusive to the chest wall and exclusively in children. I'm going to center in the differential diagnosis with fibrous dysplasia, which is the closer differential. And I'm going to present you a real case of fibrocartilage dysplasia. She was a 50-year-old female with intense pain when walking and multiple bone tumors are here. It shows it was in the vertebra, in the spine, and the ribs, and one lesion located in the sacrum, in the iliac, which is here. You can see the lesion. They can have bone deformities like in fibrous dysplasia. This is the typical Shepherd deformity with because of the weight is over here and bends the bone. This is the appearance, histological appearance of fibrous dysplasia, of bone fibrocartilaginous dysplasia. It has islands of cartilage, but not with the bone plate arrangement. And here are the curvilinear bone trabecles in a fibrostroma, like here, is a fibrous dysplasia with a lot of cartilage. There is some linear arrangement, but not so nice like in mesenchyma. Most of the islands have this arrangement. Other names is fibrous dysplasia with chondroma features, fibrochondrodysplasia, and it represents between 5 and 7% of bone tumors. It is hyaline, cartilage is hyaline, is little, the cellularity of the fibrous components is very low, and the nest of cartilage is around. And as you saw in the previous slides, that it's separated by fibro-osseous component. Okay. In this paper, they present 8 cases of fibrocartilage dysplasia and show in this table some of them can be polystotic, most of them are monostotic, and it affects young people too. A difference with the fibrocartilage mesenchyma is a unique epiphyseal plate-like cartilage. This is the main marker for this entity. This same paper by Gambarotti and from the Rizzoli Institute, as presented before, is they try to differentiate fibrocartilaginous mesenchyma bone with molecular methods. This is from the same paper and show this columnar arrangement of chondrocytes with an ossification. In 8 of the 9 GNAS cases that they did not detect somatic gain of positive for fibrous dysplasia. So this is important in this separates it because many authors think that fibrocartilage dysplasia is similar or is the same entity to mesenchyma. And that we all. Thank you. Gracias, Isidro.
Thank you. Muchas gracias, doctor Domínguez, por su presentación, por el caso muy interesante también. ¿Usted pudiera dejar de compartir la pantalla y así ya hacemos la discusión? Arriba, en donde dice en rojito, dejar de compartir. Vale, muy bien, perfecto. So, any question, remarks, opinion?
The problem is that to believe that this exists is the differential diagnosis with fibrocartilaginous dysplasia, but it was well explained, just well explained. I agree that one of the idea that it exists or not is if it is a variant or, but I think that when we have such case with atypical cells, as I previously said, this is the proof that is not a fibrocartilaginous dysplasia. Also, the fact that can recur. So we believe that is another tumor.
Do you see this is I couldn't say mandatory, but necessary? For instance, when we have the wall surgical piece, maybe with the HNE, we presumably can make the difference between both entities. But
yes,
in throughput biopsy or in small biopsy, do you see that molecular biology may provide some support to distinguish both entities?
You can do GNAS or IDH1 to rule out the differentiated chondrosarcoma that generally is high-grade malignant in the spindle cell. But sometimes it's difficult to say it's malignant mesenchyma or fibrodysplasia, and it changes because one is more aggressive than the other one. In biopsies, it's difficult. There are some radiological features that we described in our paper that can be distinguished, but I'm not. We reported, I think, also in the WHO book regarding the cross-stem medium uptake. So we put some, and also the fact that if it destroys the bone or infiltrates the bone is not a fibrodysplasia. And here you can use MDM2 to rule out low-grade osteosarcoma that does not have the cartilage. So are more clinical than morphological features that distinguish the two, but sometimes is very difficult.
Doctor Domínguez tiene una pregunta de su colega, Aide. ¿Cómo diferenciarlo con cambios por fractura?
Bueno, los cambios por fractura generalmente presentan reacción reparadora con algún indicio de que esto representa reacción reparadora con hemorragia, con proliferación de miofibroblastos y este fenómeno de zona. Perdón, bueno, ¿me escuchan?
Sí.
Sí. Yo no los veo, pero los escucho.
Sí.
Otra cosa es el fenómeno de zona. En el callo de fractura siempre hay zonas zona reparadora, zona osteoblástica, zona con cartílago. Entonces, estos serían los elementos principales. Y el acomodo como cartílago de crecimiento es característico del mesenquimoma y no de una reacción, de un callo de fractura.
Ricardo, ¿querías opinar algo acerca del caso?
De eso que dijo el doctor Hugo. la producción de hueso endocondral que puede haber en un calo de fractura no es tan organizado como en una placa de crecimiento. In a growth plate, it's not so organized as in a growth plate. It's more haphazardly found among these hemorrhage and other preparative tissue, like said Dr. Hugo. And then another thing that I would like to comment in my case, Dr. Domínguez also mentioned during his talk in nodular fasciitis. And in some areas of my case, it really remembered, we could recall the nodular fasciitis, but histologically, but the USP6 was negative, so it was ruled out. Just for completion.
Aide, Caro?
Hi, everybody. Yeah, my question is because sometimes the biopsies are very, a few fragments, and sometimes we cannot see all the context or for example, the image of, the radiography is not very good or good quality, so we cannot find anything, and the clinician just says that is having multiple fractures over the time, so they don't know what it is. And you have a very good, big problem with very, very small biopsies. That's why I was asking that, because sometimes it's very, a few things that can tell you that is this kind of entity, but sometimes with a fracture, it's so hard to do the diagnosis. That's all.
Okay, thank you. ¿Alguna otra pregunta, comentario, inquietud? Any further question? Remarks?
¿Pago?
Sí.
Este es lo que vengo para pegar.
Dr. Jumbar? We cannot. No se oye. Está mutado.
Sorry, just to congratulate both the speakers for the very interesting cases. Thanks, Dr. Domínguez, too.
So any more questions? Silvia Baguet, do you want to say something? No? So thank you very much for this both presentation. So Silvia, do you want to say something?
Not really, just to congratulate the two presentations. I think it's a very rare tumor, so we must be aware of that. But it's very difficult to make the differential. Thank you very much.
Okay, thank you to all the attendees and the speaker and the invited. And so if you don't have any further question, we close the session for today. Thank you for your time, and we'll see you soon in the next session in April. I will send you the link for you to know the date and the exact time for this session. Okay? Thank you for your time, and see you soon.
Okay.
Okay, thank you.
People.
Yeah.
Thank you. Congratulations,
Yeah.
Isidro.
Sí, sí. Ahora, si podemos quedarnos un momento, Ricardo y Sergio.
Sí, sí, vamos. compartir
no.
algunas cosas.
A la niña le ha picado una araña. Esto se pone de la caja. Dice una mosca, pero no es una mosca.
¿Qué tal, Sergio? ¿Cómo estás?
Hi, Sergio. ¿Cómo
Hola,
estás?
hola, ¿cómo están? Buen día.
¿Cómo estás?
Hey,
Me gusta saludarlos.
encantado de saludarte.
Igualmente, igualmente.
¿Todo bien?
¿Qué tal, Sergio?
Qué bonito,
Hola.
bonitos casos, lindos casos.
Preciosos, muy bonitos.
Sí,
Y difíciles. La verdad que ese de partes blandas es el primero que hay, ¿no? El que ha presentado Ricardo.
sí.
Me parece.
El componente fusocelular es el que está interesante de seguir estudiando, ¿no?
Sí, sí.
No, porque no marcó con actina, pero a lo mejor calponina, CD34, ¿no? O sea, son muy indiferenciadas. Sería interesante
Sí.
verlas.
Sí, en secuencia sería mejor estudiarlo, mejor, sí.